An ablation works by targeting the short circuit tissue within the heart. Some ablations, the ablated territory of the heart, the area that we actually ablate, is smaller than the tip of a pencil, and cure is achieved. Other ablations require much more extensive moving the catheter around in the heart to do ablation, which is either cauterization or heat energy versus freezing energy. We here at the Heart and Vascular Program have both. We've done quite a bit of freezing work in terms of ablation within the heart, and we also traditionally rely on heat ablation. With the robotic system, heat ablation is what we use. Heat ablation tends to have better permanency. It tends to give better outcomes, in our opinion, long term, with more effective lesion delivery, which is very, very important, because if you're having one of these procedures, you really don't want to have more than one if you don't need to. Sometimes, however, particularly in the young or in very small hearts or in very, very sensitive locations, we have to swap out from mapping with the heat catheter to mapping with the freezing catheter, because the freezing technology is more forgiving in some instances than the heat technology is. So what I like to tell patients is, if they come to us and say, "Doc, are you going to freeze me or burn me?" I say, we'll make that decision when we're inside your heart, but we've got both. So within the arrhythmia program, we are often consulted by pediatric cardiologists, by adult cardiologists, by community referring physicians, family physicians, and even pediatricians to take care of the young as well as patients all the way up into the 100 plus territory. We're very proud that we take care of such a spectrum of age. Probably the youngest patient in our practice is under 10 years of age. With ablation technology, we make a disposition regarding the patient's size. Not all 13 or 14-year-olds are created equally. We work very carefully with pediatric electrophysiologists around the country in terms of referring patients whom we feel would be better suited for ablation or device work at their centers. But we have done a fair amount of what I would term adolescent ablation. A lot of high school students, even middle school students, who are troubled by arrhythmias. One of our most common referrals is an athlete who's determined to have an arrhythmia problem that's interfering with their ability to play sports. Seeing a young person who's in the prime of their life can slam dunk a basketball or hit a home run and not be able to do that because of an arrhythmia is very unfortunate. So in many instances, we'll be able to work with the patient and obviously their parents in terms of targeting their arrhythmia with ablation in an effort to cure them so that they can go on to play competitive sports, including a number of local athletes who play for universities. In terms of doing the very young, in our experience, we do quite a bit of referral out to a pediatric electrophysiologist who take care of the very young.